Okay, so they're all. Today, APHP, which is a French group of hospitals in the Parisian region, and the partner of the European project NoFair, would like to share its amazing experience of air transfer of critically ill COVID patients to highlight the medical and logistical constraints accounted during this transfer.
Je parle pas, mais j'écoute. De quoi?
Pouvez-vous, can you mute?
Oui,
Okay.
ta gourde, ton manteau, tout.
Mute your microphone, please. So the first slide, please, Itamar. Okay. So to begin this seminar, Professor Francesco Della Corte, the coordinator of NoFair, will present the project and the incredible work done during this period of crisis. The monthly remote seminars have allowed us to exchange our views on common issues, clinical practices, scientific advances, logistics, and of course, ethical aspects. Dr. Le Carpentier, head of the pre-hospital emergency department SAMU 94, will explain in details the first wave of patients transfer, how the airport was transformed into a medical hub to evacuate and dispatch patients all over France to regions where there were still some free ICU beds. Then Professor Bertrand Guillard and Dr. Patrick Portecope, heads of SAMU Île de la Réunion and SAMU de la Guadeloupe, will talk about the difficulties of handling patient flows in insular areas and the need to transfer patients by air, sometimes over very long distances. The major constraints accounted in aeromedical patient evacuations and the related situation show how this pandemic became a disaster with a particular focus on oxygen. The oxygen issue is, however, known to be a limiting factor in disaster plans in case of a large number of victims with respiratory distress. These events confirm the validity of the European Commission's work on a fleet of multi-purpose medium and long-range airborne vehicles to use in disaster. The consortium work has also highlighted the discomfort of biological PPE worn by medical teams. And we are pleased today to present a promising hood created in partnership with BAE System, the Lancaster University, and St. Thomas School. Francesco, please, it's for you.
Yeah.
Next slide, please.
Bon après-midi à tous. Good afternoon to everybody. I am very pleased to participate to this webinar. I like very much the idea to give you some information about the project that I have the honor to be the coordinator, and it should be very important for me to give you some information about what we have done, and what especially we are doing, and what probably we are prospecting to do in the future. So the project is composed by 18 partners. The duration is 5 years. We started in 2018 and we are going to finish in 2 years. The budget for the project was about 3,500,000, and this was the coordination budget. The budget that you see on the screen is the coordination budget. But the project of the support, the financial support by the European Community was about 3,500,000 euro. May I have the next slide? Should you move it? Oh, great. So the main aim of the NoFair project was to link together most of the European practitioners, suppliers, researchers, and policymakers, with the goal to achieve a common understanding of needs and priorities, to try to fill up the operational gaps, and also to pinpoint areas for future research. Next, please. Oh, you can see here the names of the participants to our project. You know that they are very well representing most of the European countries. Next, please. And they are mainly composed by, as I told you before, suppliers, practitioners, academicians, and this makes these three different participants will join together to talk, to work on these three main pillars that are the acute care of the patients, the operation in security related incidents, and training and education of personnel and volunteers. There are also two branches that are connecting these three main pillars. They are ethical aspects and humanity aspects. And the second tightening aspect is the innovation monitoring and the uptake plan. The next one, please. So what we are doing normally, or what we were expected to do, and what we did exactly in the period before COVID. So we organized workshops, exercise and demonstration that were tackled with the lesson learned, needs and trends with focus on new threats, working on trying solution for the current and future innovations, and to give our feedbacks, the feedbacks of our meetings, and the recommendation from our meetings for practitioners and suppliers. So it was something like a virtual cycle that should implement knowledge and dissemination of this knowledge. Next, please. So we started also with some consortium activity that was the creation of a transactional dynamic portal that was uploading all the research that were done inside our activities. And the project moved to events, workshops, meetings every 6 months, debates, and also full-scale exercises that should provide in some way the evaluation of the content that were supplied by suppliers and that were proved and sorry? Oh, there is no problem, okay. And so to try to match together what the expectation of suppliers and the expectations of the practitioners. Next, please. So we had an innovation watch that was to take all the information that we were faced on at least twice a year. We were also monitoring and trying to get a common bench of action with other EU projects, and also funding some opportunities that were given by this collaboration. Also, the exploitation of our activities has been taken into account. So market analysis, business models, business support. And another point that we tried to develop were standardization of specific topics. Next, please. So we started, these were what we did in the last year. We made, in fact, unfortunately, our last meeting in Tel Aviv that was without COVID, even if COVID was spreading in some part of the world. On January 24, the first case of COVID-19 was reported in the European Union, and on March 9, we have the first webinar on COVID-19 response. And on March 11, the Director General of the World Health Organization declared the COVID-19 as a global pandemic. So what happened? That our activity was really impacted by the effect of COVID. And we have to change a bit our orientation in this project. So next, please. So, and how did we manage it? We started our work together, interaction with other projects, trying to make the point on very important topics that were leading the interest of the community of emergency in this specific problem. And so, as you saw, we started a lot of activities managed by the web packet managers and coordinators. And as you see, we had a lot of topics that had been taped and put on our portal. And if anybody of you is interested to get some information about these titles, you can easily enter the website and the portal and have all the information of these activities. You see that this slide contains all the activities made until May 20, but we continue quite twice a month to have this kind of seminars that brought a very lot of progress in our activities and a lot of networking activities inside not only the partners of the No Fears, but also external partners. Next, please. So from that day, we started that, and we with the aim of involving existing global involving and establish a strong existing global network of practitioners, creating opportunities for quick and dirty information. You have to know, as you really know that at that time, quite nothing was known about this pandemic. Now the situation is, of course, very different, but at that time it was very important for us to get together to try to solve our single problems. And this was very fruitful, of course. Unfortunately, we in Italy were probably the first European country that was impacted by the pandemic. So we were very, very active in trying to expand our informations to all the other partners. And also exploring how different countries responded to the same challenges in different stages of the pandemics. And it was very useful for us to know what was coming out internationally. And after that, we were also interested in knowing how suppliers were producing tools that could be or have been used in our daily activity. Please, next. So at the beginning, we had lack of knowledge, as I told you before. We were good discussion about the personal protection devices and about the risk protection. We need to share contacts among specialists to anticipate possible problems. We started a bit later to have an interest on impact on emergency public health, and after a new interpretation of ethical consequences that were related to the pandemic. Next, please. And among the ways we in Italy, we are going to manage the fourth wave in a very quiet way, I want to say, because we have reached quite 90% of Italian people that have been vaccinated. So the implementation of this pandemic in this fourth wave until now, at least, is a bit weaker than in the previous three. So we are looking, among the ways we were looking at the new variants, we started to talk about communication to the public, the so-called infodemia. We discussed to speak about restrictions, social restrictions, about disparities, about vaccines. So during the time, we changed a bit our orientation, looking to the new problems that we were expected to get. So I don't want to take time for your discussion. That would be very interesting for us. We will. We are very, very, very interested in the title of this webinar, and I am sure that it will be very fruitful for our project. So thank you very much, Catherine. for having organized it. And I think that we will meet in Oslo physically next week. And this will be the next person and present meeting in presence. And this will be a step forward, I think, for all our activities. So thank you very much, everybody, from the NOFIA for having accepted to participate to this webinar. Thank you very much and good work.
Thank you very much, Francesco. And of course, we are very glad to be with you next week, and very glad to participate to this project. Next slide, please, Itamar.
Itamar has a connectivity issues, so I suggest that the speaker starts and Itamar will be reconnecting.
Okay.
Just a second.
Well, I had prepared maybe one slide about, so next slide, please, Itamar, and it will be perfect.
1 second.
Yes. So I wanted to share with you one slide explaining what SAMU represents and means, It is a medical call center and a pre-hospital emergency service. And our SAMU medical teams were in charge of transferring COVID patients by ambulances, of course, by train, by helicopters, and by planes during this pandemic crisis. But now I will give the floor to Eric, head of our SAMU. So, Eric.
Bah, tu m'as coupé la vidéo.
La vidéo, tu l'as retirée. Okay. So, Itamar, next slide, please.
Yes, good morning, everybody. I present you during the first wave. We transferred the regions where.
Next slide, please, Itamar.
Good, fine, thank you. During the first wave of transfer, the regions were affected differently, and patients had to be transferred from one region to another by ambulance first. Then 200 patients were transferred by train. In the second step, transfer was carried out by helicopter and airplane in order to transport patients over varying distance of far regions. In addition to that, the patients are not grouped together like it was by train.
Next item. Okay.
This air transfer requires several criteria of to be respected. A standardized method, strict medical criteria, in example, FiO2 less than 80%, 60%, excuse me, PIP less than 10 yes, and additional human resources, a special beach on EVS and material. Next, please.
Next.
Particular attention had to be paid to the power supply and batteries, safety to oxygen transport, and to avoid contaminating the team. Human resources were also an issue. One doctor for every 2 patients was required, one nurse per patient in addition to first aid helpers. We face ethical problem when the family did not agree to the transfer, since the patient not being able to consent. It took a few hours to organize a medical hub in the nearby airport in order to evacuate patients by civilian and military planes and helicopters. The only hub was proven its usefulness. The location of this evacuation center in an airport is rational because of its close to the main road. And in Paris, it was in the center of the region of Paris. In case sometimes serious happened, the airport will always be one of the first seats to be rehabilitated and secured. This is an example to be remembered in many major events in France or abroad, and to be included in our hand-on training. The variety of vehicles has made it possible to transport from one to four intubated patients with ready of action, allowing a wide choice of the destination. Information of this airborne means to given and thought in the disaster medicine course in France. I must also mention the international aid we have since where we were able to transfer patients to Germany, Austria, Luxembourg, and Switzerland. Thank you very much.
Okay, next item. Okay. So thank you very much, Eric. But now we have another issue with insular regions, and we are pleased to give the floor to Professor Bertrand Guillard from Île de la Réunion. Bertrand, it's to you. It's for you.
Thank you, Catherine. Good afternoon, everybody, and thank you to No Fear for this invitation to present our experience with air evacuation of COVID patients in the Indian Ocean. Next slide, please. Well, so after experiencing a first COVID wave in April 2012, Mayotte experienced a sharp and significant increase in COVID cases in early 2021. And this increase was notably linked to the appearance of the South African variant in our area. On the graph, you can see in blue the number of diagnosed cases in Mayotte, and in red the number of patients hospitalized in intensive care units. To be clear, Mayotte is a French department located in the Mozambique Channel, and which usually has only 16 intensive care beds for almost, we don't really know, but around 200 or maybe 400,000 inhabitants. So after having doubled the number of intensive care beds, notably by calling on reinforcement from the army, it was necessary to consider transferring patients in order to treat them well. As a transfer to France, more than 8,000 kilometers away, was considered too complex, too difficult, not feasible, it is quite naturally Réunion Island, located at 2 hours flight, which was chosen to receive these patients. Next slide, please. So the flights were carried out on a dedicated aircraft. You can see it on the picture. It's an Embraer ERG 135 of the company Amelia, which is usually based in Mayotte. This aircraft was initially equipped with 2 stretchers and later with a third one. With the reinforcement of the second crew, we were able to increase the number of rotations to 2 per day and 7 days a week. The dedicated medical teams were essentially the teams of the SAMU of Réunion Island, supported by a reinforcement of 27 people of the different SAMU of mainland of France, doctors and doctors. Yep. Okay. The teams of Mayotte were, well, actually already largely involved in the management of the epidemic on the spot, so they didn't join us for these transfers. The specific medical equipment dedicated to these air transfers was both of Réunion and Mayotte. Next slide, please. So the most important issue which kept us busy through the crisis was the choice of patient eligible for transfer. They had to be severe enough to justify resuscitation, but not too severe to tolerate air transfer in her hypoxic and hypobaric environment. After a few days, we decided to transfer only intubated patients. They were more stable for the transfers. We set up clinical criteria to identify eligible patients. These criteria were based on ventilatory, of course, and hemodynamic parameters, but also on weight, renal failure, and of course, the agreement of the family. It was always necessary to pre-select over 5 or 6 patients each day, the day before, to be sure to have at least 4 to transport the next day. Actually, some of them warned during the night and were no longer transferable the day after. The other important point of vigilance was the management of aeronautical oxygen. Oxygen usable in a plane, as you may know, is specific and packaged in cylinder approved by the International Air Transport Association, IATA, and a bottle, the one you can see on the picture, contains about 3,200 liters of oxygen, and once empty, it must be filled by an operator and in specific conditions which are possible only in France, in mainland for us. In Réunion, we have only 19 cylinders, and in Mayotte, they have 16 of them. So it was necessary to consider an accelerated series of replenishment of this oxygen, and this was sometimes a real problem. And finally, a couple of logistical points required also regular management and readjustments, such as the follow-up of medical equipment between Mayotte and Réunion Island, or the organization of transfers between the plane and the hospitals. For instance, in Mayotte, these transfers usually occurs in helicopters, but sometimes by boat, because there's a piece of lagoon between the hospital and the airport. So it was a way to transfer patients between hospital and the airport. Next slide, please. So in total, this organization enabled the transfer of more than 90 patients over 4 weeks. Most of these patients suffered from ARDS, and although this was initially considered as a contraindication, one patient was transported under ECMO, ECMO, We didn't have any death during the transfer, even if almost all the patients was on a ventilatory point of view during the flight. And finally, it seems that the 30-day survival of the transferred patients is similar, is the same to that of the patient who remained in Mayotte, in ICU in Mayotte, but with, it seems, a slightly longer duration of hospitalization in the intensive care unit. These data are still being consolidated. The increase of patients in Réunion Island required also an increase in the number of ICU beds in our own island, from 60 to more than 100, 110. And this was in a context of slight COVID epidemic outbreak in Réunion. So This forced us to anticipate a possible breaking point and to organize the first evacuation of several COVID patients on the long-haul flight to France. France is more than 10,000 kilometers away from Réunion Island. This model was then taken up and developed by our colleagues in Martinique and Guadeloupe, but this is another story, and I let Patrick Portocop explain you that. Next slide. So I thank you for your attention, and I leave you with these pictures taken during this intense period for us.
Thank you very much, Bertrand. We understand how it is intense, and complex also. And it was a very good job from your teams, and Mayotte and Île Réunion are raise very specific problems. So thank you very much for this discussion and to share this with us. Patrick?
Thank you very much.
Good morning, everyone. I'm very glad to be with you, and I'm going to tell you what problem we have with oxygen projection in insular environment in Guadeloupe, French area in the Caribbean. Donc, Guadeloupe is a French department located in the Arc of Lesser Antilles in the Caribbean, territory of 1,628 water kilometers. And there is no local oxygen production.
Next slide, please, Itamar.
Thank you very much. There is no local oxygen production in our area, and the monopoly of oxygen distribution on the territory is by Air Liquide and the society SOGIG. Next slide, please. During the crisis of COVID-19 on Guadeloupe, we have very the consumption of medical oxygen increased significantly during the period of July or August, and the large number of patients in the massive use of OptiFlow. And you can see that we was very increased for the possibility to resupply in our hospital. It was very difficult to have the security, and every week it was a difficulty for us. So next slide, Frank. What solution do we have? We have the possibility to have liquid oxygen containers, and can be shared for boat or by plane. And you have an example, transferred boat liquid of oxygen from Guyana to Martinique. You have the possibility to have oxygen concentrator in a plane or boat, and we can have unloading stock of oxygen concentrator from Paris. In the example of Santé Publique France, we received the plane with 3,000 concentrator from Paris. So we think that the anticipation of oxygen projection is essential in case of chemical or biological crisis. The on-site production of medical oxygen for healthcare institutions should be developed, and strategic storage of oxygen concentrator is a priority objective for sanitary crisis gestion. So we are in a reflection with the authorities to find a solution to have better security on the oxygen problem. Thank you.
Thank you very much, Patrick. We knew that oxygen was an issue in a disaster crisis, but you know it's really a demonstration, and you experienced this, and I hope it will help us to face new crises in a better way. So
Thank you very much.
that was what we wanted to share with you, and about air transfers, you know, because we had specificities in mainland France, and insular areas raised some also some other problems, you know, and that is something that was quite unique for France. Now we will share some innovation, because, you know, of course, we have team transporting patients, and we have to protect our teams. And we did very few research about biological PPE. And we all faced problems with this PPE, and especially for protecting airways. And we were told that there was a very innovative hood created by BAE, the Lancaster University, and St. Thomas School. And we are very pleased to discuss this new innovative hood with you. Please.
Good afternoon, colleagues, and thank you for the opportunity to present to you all as part of the No Fear project. My name is Stuart Hosking-Dern. I'm Head of Resilience and Patient Flow for the University Hospitals of Morecambe Bay. I'm a former paramedic myself, so I've had clinical experience and latterly hazardous materials specialist working with a nuclear environment, so used to dealing with hazardous substances of a wide range. In the room with me here, I've got Neville Clokey, who is the Managing Director of Landcastle, who is the manufacturer of the hood that we've designed. Alan Felstead from BAE is our human factors expert and set up some really innovative ways of engaging with clinicians around the suitability of the hood to be deployed within a clinical environment. And also on the camera you can see there is Michael Fraser, who's our lead engineer, and Paul Douglas, who is our project management specialist and kept us all on track. Next slide, please. And again, next slide. I think what we've all seen during this pandemic is the range of PPE that has been used very extensively. Some of it successful and some of it less so. And certainly here in the UK, as the first wave of the pandemic really hit and the international supply chains failed, availability of PPE became something that was putting the ability to provide clinical care at risk, because we were so low in some areas of the right types of PPE. And certainly there, the bottom mask you can see there is the FFP3. That particular product is a 3M product. And during the first wave of COVID, America invoked a Korean War Act and sequestered all stocks of American-made products to be returned to the US in order to protect their own healthcare workers. Understandable. The consequence of that, though, was clearly that we had to have a different source of PPE. And then in the bottom right-hand corner there about the face fitting. As a trust alone, we have face fitted more people in the last 12 months than we had done in the previous 5 years. And mask fitting in itself becomes an industry, and setting up teams to do that regularly, again, is difficult and remains so to this day, particularly where from an end-of-life care perspective, we offer the ability for family and loved ones to come and be with their relative in their last dying hours and days, but they have to be protected as well. So that's another PPE constraint put upon us. And the cost involved also rocketed. In the top left-hand corner there, the Type 2R, the fluid repellent standard surgical masks that we're all used to. We were buying those pre-COVID at about 17 pence each. At the peak of the first wave of COVID, the international market went up such that the cost of one of those masks was in the region of £6, so about €7.5 per mask. So an enormous increase in cost. and that gets borne out by the taxpayer here in the UK. Next slide, please. In terms of the collaboration and how we got to where we got to with this very diverse team of experts and specialist companies, during the first wave of COVID, the curtain hooks that went around the patient bed was our single point of failure in those early days. And working with BAE, Lancaster University and Ripley St Thomas School, they all produced using 3D laser printers the hooks that we needed. And that formed a relationship with BAE that then led us to create additional hospital beds. We knew that we were around about 250 beds short based on COVID projections, just for the Morecambe Bay area alone. And working with a great team from BAE, we designed and built 197 extra out-of-hospital beds in 10 days. An absolutely phenomenal achievement. So much so that some of our clinicians were in tears at the ability for community partners to step in and give us the extra resources that we need. And then the introduction to Lancaster comes about from an initiative with a local group of volunteer women. Again, the supply chain on scrubs. So the theatre scrubs that we're all used to wearing, that became difficult. Obviously, globally, people wanted to change out of uniforms into workwear that we could wash and launder on site and not take the risk of a contaminant home to our homes and families. And through Lancaster, this team created over 5,000 sets of scrubs for the hospital, which was a fantastic achievement. And so the relationship's now formed where, when it comes to creating the hood, I've now got a network I can call upon. Next slide, please. We've all seen these pictures. PPE, in terms of a hierarchy of control, is always the last line of defense. We know that the wearing of PPE causes more problems. Some of the things that we have experienced in the UK.
Max, aus. Nee,
Oh, there we go. Not all the PPE types fit our colleagues. The majority of the PPE that we're wearing has been designed for industrial application. It is therefore designed around the 95th percentile male. In the UK, the NHS is about 70–75% female. So already you are trying to get PPE to fit colleagues for whom it was never designed. We know that with some of the reusable mask products, where you can adjust the tension on the elasticated straps, colleagues would over-tighten the straps out of fear, and what that then does is that creates pressure sores, as you can see there in the bottom two pictures. But also the layering of PPE then causes other fatigue issues and human factors issues with regards to how our colleagues carry out tasks with some quite constraining PPE that they're not familiar and used to. And the last element that came out very glaringly were our colleagues from BAME backgrounds, for whom we know that their different facial profiles, again, doesn't work with a lot of the PPE. And that communication is a real barrier at this point. So as you can see in the top picture, once your face is covered, once your mouth and your nose are covered, your ability to communicate is really restricted. We've got patients who need to lip read, for example. We've got colleagues who need to be able to see a smile, that those non-verbal cues that we can give. We had colleagues inform us that being able to care for dying patients was incredibly hard when they couldn't even offer a smile of comfort to a patient who they knew was dying. And some patients died with all their last images being was a set of eyes. That's all they could see on some of our colleagues. So we set about to try and rectify some of these challenges. Next slide, please. There are commercially available hood systems on the market. Again, they are industrial in nature and not designed around healthcare settings. And as you can see there, this is one of the products that is available on the market. We tried to buy 1,500 units, but the global supply chain was so stretched, all we managed to buy was 98. We've currently still to this day got 200 colleagues who don't fit any PPE currently available, and therefore they are not working clinically as we would want them to. It is estimated in the UK alone, there could be up to 70,000 clinicians who don't fit PPE, who are having to have their work life restricted and not able to deliver patient care, and that has a consequence on our ability to deliver care. Next slide, please. As you can see, the Morecambe Bay Hood really is a Morecambe Bay initiative. All of us who worked on this project all live and work within the 1,000 square miles that we as a health trust cover, and for a population of around about 300,000 citizens. In setting up the project, there were some key design objectives that are placed on the team that we wanted local design and manufacture. With the exception of the blower unit, which comes from Switzerland, all other elements of the hood are manufactured in the UK, and some of them as close as 3 miles away from the hospital. We wanted to be able to protect the price for the NHS, so we've come to commercial agreements with Lancaster about the price protection for the NHS, so that in future pandemics, we won't see those huge surges in PPE that, whilst we had to pay them in the last COVID surges, ideally, my objective was if we could make the NHS protected from those surges, that would be a great outcome. Next slide, please. And as you can see there, we were successful. So key elements of the hood, as you can see there, it's got a very large face visor. And the clinicians during the human factors trials were really interested in that ability to be able to communicate both visually and verbally with each other. That has got great responses then to our patient care, and those patients that we know have been treated by clinicians wearing the hood have commented upon how nice it is to see a face. Because what they have been used to during the pandemic is everybody in head to toe, and all you can see is a pair of eyes. The cape has been designed in such a way that we can protect the wearer on a 360-degree basis. The fabric is fully cleanable inside and out, so it's been designed specifically for the hood. And unlike a lot of the commercially available hood systems, we've taken the seal away from around the face and placed it around the neck. And we found during those human factors trials that gives greater comfort to the wearer. We also believe it gives greater protection from the risk of inward leakage, because the seal is less likely to be broken because it's not on your face, where you're more likely to want to touch your face, adjust glasses and things. And as you can see there, our colleague who is wearing the hood is able to safely wear glasses as she would need to carry out her clinical duties. And that's important because a lot of the other mask and hood combinations and visor combinations often clash with glasses. And that has a human safety, a human factors impact in terms of our ability to care. The cape is designed in such a way that we can wear theatre gowns and aprons over the top. It doesn't interfere with the way the hood functions. So from a control of infection perspective, we can give the wearer a full body protection if we needed to, by the combination of wearing with long sleeve aprons, double gloves, etc. Endurance from wearing the hood, we've noted our colleagues find wearing this for 3, 4, 5 hours is no problem, whereas wearing a disposable mask isn't advised for that length of time. So the frequency of changing PPE goes up, and we know that from a risk of cross-contamination, the more you change your PPE, the more likely it is there will be a transfer point. The hood itself that we've designed here is significantly lighter in weight than commercially available hoods. And again, when you're trying to protect predominantly a female workforce, weight becomes a factor in endurance. And during the human factors trials, colleagues said psychologically they felt safer. Even though the filtration is the same as a disposable FFP3 mask, psychologically they felt safer wearing a hood, and that has got to be better from a human factors perspective if we're trying to reduce medical error. And then latterly, with the involvement of BAE, the inside of the hood has got a really innovative way of distributing the air. You won't be able to see it on here, but if I've got some pictures, I will share them with you afterwards via Catherine. The way the air distributes is there is no void, pressure void inside. The air blows out in such a way that it's a constant flow, but we found with colleagues who wear contact lenses, it doesn't have a drying effect on the eyes. And that actually we all know from when we were designing and building the hoods, working outdoors as we were back then as a COVID secure environment, wearing the hood outside in the glaring sunshine was actually cooler than being in the sun itself. So it's a really great opportunity for clinicians to be protected in such a way that we afford them the highest level of protection. Because from my perspective, one of the great things about the hood is that from an FFP3 mask perspective, I cannot guarantee that they'll always wear it the right way every single time. Therefore, I cannot guarantee that that mask will provide the right level of protection. The hood itself does not require mask fitting. It is a universal fit. There are ways to adjust the headband so that it can conform to a variety of head shapes and sizes. And from our BAME colleagues' perspective, I don't need to ask them to be clean shaven. So colleagues who have facial hair for faith reasons, we allow them now to express their faith because we don't require them to shave because the hood enables them to wear PPE to the correct standard and doesn't conflict. So all round, we've seen some really great feedback from our colleagues, and there's a link there in the presentation to the actual video where you can hear testimonials from some of our clinical colleagues. And I think from my perspective, it's a great opportunity to work with colleagues across Europe and across the world, really, to look at how opportunities like this type of hood could be better used in the future. I think from your air transportation perspective, colleagues would have found this much better to wear and be able to communicate much better with each other. And being in those confined environments on helicopters, you won't dislodge this, so therefore the risk of a mask seal failing and therefore you becoming yourself contaminated is by and large eliminated by this type of product. And that's our presentation really, and I'm happy to take questions from colleagues at this point.
Thank you very much for this presentation. You know how I am convinced by hoods, and I promote this protection for our airway, and I hope to try one of those maybe next week. No, I am joking, and I hope you will have also a price protection for France, maybe, and because I would like that medical teams be protected by this type of hood. And we will get in touch with you because our National Biological Commission is working on this topic, and we will contact you because it's one of our teams of research. So thank you very much for sharing this innovating product with us, and I open the floor to any questions of the auditors. If you have any questions about the first presentation and about this hood, please, it's up to you. Hi, Itamar, Francesco, Peter, do you have any question?
Nothing. Very.
Okay. If not, it's 4 o'clock. So I will end this seminar, and thank you very much for all speakers and for listening to this presentation and share with us complexity of air transportation of critically ill COVID patients, and to share this innovative product that will help us to transfer patients and to wear PPE for a long time, a long duration time. Thank you very much and have a nice day.
Thank you very much, everybody.
Thank you. Goodbye.
Bye.
Thank you.
Thank you.